All right, so that's a good place to transition. And so we've got John Blebea is going to kind of talk about what that future looks like and how this impacts the reimbursement, the financial side of life. So, John?
Well, good morning, and I'm the last presenter before lunch, so hang on in there with me. It's great. It's been a great series of presentations this morning, what we've done, plans and visions for the future, and it's very exciting. It's very positive. And now I'm up here to talk about reimbursement. So hopefully not too much of a downer. My disclosures, I am the AVLS advisor to the RUC and a member of the Practice Expense Subcommittee. So hopefully I can give you some insight from real experience. What I want to talk about this morning is really to give you the information to better understand how reimbursement is determined, what the challenges are for us, and the expectations that physicians have going forward. I know to some of you, you may be aware of this, but being the AVLS advisor for the past 5 years, I've been struck with how little information physicians and others really have on how this whole process on reimbursement is determined by CMS and by extension, everybody else afterwards. So when we're talking about reimbursement and how that's determined, there's two aspects of it that you can consider to better understand it. One is the one where physicians are involved. And in that area, we're talking about the AMA and the RUC. And then the second part that follows inevitably is the political aspect, which involves CMS and Congress. The two are very different. One follows the other, but you've got to think and impact both of those to be successful if there's going to be any changes. So on the first part, where physicians are involved, we all know that CMS, Centers for Medicare and Medicaid Services, only determines payment for Medicare. But it's inevitable that everybody uses those determinations and those policies and those numbers for payment. So other insurers generally pay nationally about 139% last year as compared to Medicare. And that number kind of stays pretty constant. So whatever Medicare decides to pay for venous interventions, other insurers will follow. So in order to make that determination, CMS contracted the American Medical Association to provide advice, and specifically through relative value units and the RUC process. So how did this develop? How did we get to where we are now? We all know that historically, physicians were paid based on charges. Those good old days, which most of us were not here to enjoy, where you decided that it was going to cost so much money, and that's what insurers and individuals paid you. That process and its expense was evidently not going to be tolerable for government because medical expenses were going up so high. So then back in 1986, the Healthcare Financing Agency, before CMS, gave a contract to Harvard University to develop a method to assign a set of values to everything that we physicians did, from which they could therefore define how much money to pay for such services. The so-called resource-based relative value scales, RVUs for short. Then the Budget Act, having done that, Dr. Hsu spending 2 years doing that, the Budget Act of 1989 mandated such payment systems, and that was fully implemented for everything by 2002. So, relative values. They broke those down into 3 categories, 3 components, so that the cost of a service is really determined by the amount of work that a physician does, associated practice expenses, and particularly back in those days, liability insurance being such a variable, they included that as the third portion of it. And when you break it down, you see that about half the work involves what the physician does, about half of it is the practice expenses to getting that done, and liability insurance is about 4%. Those are the components. Now, when you take a look at more of the details, and particularly practice expense, as we all know, and we'll talk a little bit more in a few minutes, is broken down into two different categories. It's not all put together. One is the direct expense, okay? The non-physician labor, the catheters, the stents, your imaging units, those are the direct expenses. The indirect expenses are the administrative fees, your secretaries, your nurses, any other associated office expenses, but not your mid-levels, nobody that can directly bill. Direct and indirect, an important component. And these are calculated based on the recommendations made to the RUC by the Practice Expense Subcommittee, usually routinely approved by the RUC. And there's a lot of back and forth, a lot of details going into making that determination. And it's interesting, being on it, I can tell you, as an actual experience, we had a discussion a couple of years ago in which, for a particular psychological evaluation, psychological counseling session, the discussion was, should the RUC provide the expenses for 2 Kleenexes or just 1 Kleenex per patient per counseling session? So it goes down to that detail. And on the one hand, it makes it challenging to stay awake through all those discussions. But on the other hand, it reflects the fact that the physicians and the members take a lot of pain to correctly and adequately look at all the expenses for any particular portion of work and things that we do in the office. It's also interesting, actually, as well, that to make the final determination for big expenses, we need invoices to convince ultimately CMS that, you know, they should allocate $1,000 for an ultrasound unit, for example. What's also interesting is that when you take a look and actually experience it, in many cases, 1 or 2 or even 3 invoices is sufficient for CMS to provide national coverage determination that may affect hundreds of millions of dollars. But this is the way policies are made. Now, once those RVUs are determined, there's a practice cost index that's based on geography. So we all know, can appreciate, things are much more expensive in California, say, than maybe in Alabama. So there is a correction factor there, which is good. And all those 3 categories are added together to come up with the RVU, relative value for each particular procedure that we do. But here's the kicker. The final correction, if you will, having gone through all these details in the committee and arguing about the number of Kleenexes and getting invoices, in the end of the day, there's a conversion factor. Okay, and CMS takes all this and says, that's great. For this procedure, the true value is $1,000. That's great. Okay, we agree with that. We buy that. You've got the documentation. But then at the end, there's budget neutrality. So for Medicare Part B, for all the expenses and procedures that physicians are paid for, the budget is fixed. So at the end, CMS comes around and says, okay, all these procedures and approved procedures are going to cost $100 billion per year. But CMS budget for Medicare Part B is only $60 billion. No problem. We'll just give you only 60%. If you have already gone through this detailed process and determined that an appropriate reimbursement for phlebectomy is $600, that's fine. We won't argue with you, but we only have 60% of that. So you're only going to get $360. The conversion factor is determined each year. For example, in 2020, it was $36.09 for each RVU value. That went down last year. That went down to 2021 by 3.3%. Last year, most of you were familiar. The proposed decrease was 3.75%, but Congress assigned additional monies for 3%, so it only went down to 0.75%. And if you haven't yet heard, the proposal for next year is to cut it down and bring it down by another 4.4%. Now, we blame CMS, we advocate, we lobby for CMS, but in this particular instance, CMS is rather limited. Their hands are locked because of budget neutrality, which was incorporated by congressional law. They only get this much money, that's it. Okay, budget neutrality. Let's go back a little bit on the details. So the Relative Value Scale Update Committee, shortened to RUC, which makes all these determinations, was put together in 1992 with the initial contract. The AMA has the contract and is comprised of 31 members. That's it. 31 members make this decision. You can tell here by membership that these are the major medical societies. So for the subspecialties that we're talking about, they're not represented here. It's cardiology, not interventional cardiology. General surgery, vascular surgery has the ability to rotate once every 3 years. Radiology, not interventional radiology. So 31 individuals. These are closed meetings. They are not a public forum. People can get in and listen, but they cannot speak to those meetings. And the RUC has done a lot of work. They've looked at over 3,000 now CPT codes have been reviewed in detail. Anytime a CPT code is changed or there's a new procedure that's been approved by the CPT code, it requires going through the RUC for values to be determined. Now, once that's determined, these are sent to CMS. CMS generally, but not always, approves those recommendations. And once approved, as I mentioned before, they really become default values for all insurers. In addition, it's required to review these RVUs no less than once every 5 years. There's a number of thresholds that will identify new or old codes to be reviewed again if the numbers being done are growing significantly. If the amount of money being spent on a procedure is growing significantly, they have to review those again. I mentioned to you already, budget neutrality, it's critical. And essentially every time a code is reviewed, and this is done, the meetings are held twice a year, a new code or an old code has been upgraded. If that implies that the total cost goes over $20 million, the budget for CMS Part B is approximately $60 billion a year. If the total budget is increased by more than $20 million, budget neutrality comes into play and everything else decreases. So it's specialty against specialty. If neurologists come up with or neurosurgeons come up with a great new procedure that's going to end up spending $10 million a year, well, that's going to be $10 million that's going to be taken from other specialties. So how can 31 people alone do all this and make all these determinations? Well, besides those 31 members of the RUC, one physician is represented from 119 specialty societies from the House of Delegates. The AVLS is amongst those, and these advisors to the RUC are very important in assisting the RUC to make their decisions. They represent the specialties and the society's views. They comment on on anything coming up for review. As I've said, I'm the RUC advisor. Marlon works with me as the alternate, and couldn't do any of this without the insight and experience of Mr. Robert White in the back, who can correct me today if I say anything wrong. The RUC, this whole process of reimbursement determination is an ongoing cycle. The RUC is kind of at the center there at the bottom. The RUC decisions goes to CMS, as I said. I don't think I have a pointer. From there, they decide how much payment is going to be made by Medicare. If they have questions or if other questions are brought up, it goes to the CPT editorial panel to decide to change the description of a particular procedure or new procedure. Or CMS itself may ask them to review things. And then once there's a question comes up, or if there's new procedures that are applying for reimbursement, a letter is sent out to all the advisors and the RUCs saying, are your societies interested in this new procedure? Do you want to comment, or do you want to comment on potential reevaluation of phlebectomies, for instance? And then a survey is established and sent out to a random set of physicians doing those procedures. It's brought back, it's interpreted, it's interrogated by the societies and presented to the RUC to decide what to do. Advisors are very important in each of those aspects. CPT advisors, AVLS, RUC advisors from the AVLS, for us to keep tabs on what's coming up, what's to be discussed, and for us to, at every level, to try to have some input on what the ultimate decision will be. But at the same time, physicians are very important in this survey. And I'll comment on the survey for the physicians here and for everybody else to understand how critical these surveys are and what an important role that they play. Surveys can be decided to be sent out from CMS or from the AMA if there's been high utilization, rapid growth, expensive procedures. If it's questioned that maybe some procedures are being done separately, which should be bundled, or if there's new technologies or new procedures. And the key to these surveys are to determine how much physician work is being done. And I think it's eye-opening to understand how this information is obtained. The surveys have vignettes, short stories, 2 to 3 sentences at most, saying, okay, this is a representative patient for this procedure. This is an important area where the societies and the RUC advisors play a critical role to define what this vignette is going to be. Is this central line that you're putting in going to be in a child or in an elderly incapacitated patient? Because that implies different degrees of work and physician effort. Who is going to get those surveys? Okay. Another key question, and here RUC representation and specialty designation is critically important, because when these surveys are put together, the lead specialty and the lead society decides how they're going to write up that vignette. Is it going to describe young people, old people, whatever? So the lead society gets to kind of set the stage and ultimately influence what the results of these surveys are. We are not a recognized specialty. We are never identified as a lead society. And therefore, without being a recognized specialty, we cannot take the lead role in these surveys or advice. Now, I will tell you, I think we've been very successful. We've been very influential because of our relationships, both personally and professionally, with the other societies. But de facto, de jure, you have to be a specialty to be identified that, yes, AVLS phlebologists do 20% of this type of work, and therefore they should take the lead on this survey. We cannot do that now. At the same time, as I've mentioned here at the bottom, we are the only society primarily representing venous specialists in this process. Okay? AVF does not have a RUC advisor. SBS has been very collegial, collaborative with us, and to the degree that venous procedures have come up, they've involved us, they've deferred to us, and we're very appreciative of that collaboration. Another interesting aspect, so these surveys are critical to determine the value of any procedures, but how many surveys do you need? Is it not astounding to take a look and say that for codes of 100 to 1 million claims per year, all you need is 50 physicians to respond to the survey. That's it, 50. For those less than 100,000, 30 people can ultimately determine how much you get paid for throughout the country. So as I speak to our societies and to our members, it's critical that we educate them to respond to these questionnaires. I just responded to the one through the SVS on central venous lines just a few days ago. Okay, it's amazing how few physicians respond to these surveys throughout all the specialties, not just us. The physician work, yes, yes, Steve. I'm sorry?
Societies decide, so if somebody is not a member of SVS and they're taking the lead on somebody with veins, only SVS members will get that questionnaire. And so if someone here is not a member of SVS, they're never going to get.
That's correct.
Regarding the cost.
That is correct.
On central lines, SIR is involved also, I thought.
Oh, yes, SIR, that's not, so for those,
Yes, but I'm saying, if someone's not a member of SVS, they're not going to get the input.
I'm never gonna get that cert on vein here.
that's right. So the CMS and the RUC has a percentage. So for any particular procedures, they identify the specialties and say for central lines, 30% are done by interventional radiologists and 25% by vascular surgeons and 10% by cardiologists. It will go through those societies, okay? But if you're not identified as a specialty, you're not going to get that. So it's not limited to the lead societies, but to identified societies. Robert, I saw your hand up. Do you want to make a comment?
John, a few people may be confused, but if the code is specific to vein care, hypothetically, if 36471 decides to get surveyed in 2023 or 2024, the AVLS will survey its membership because we are a participant in this process. So we decided not to survey this current code because of we didn't think it could get membership because it was a central venous PICC line vignette. So, but I think people may have been confused that we don't even survey vein codes.
But we are never the lead society.
And we're not in control of our own destiny. I think you're saying that we have to be perceived by those determining who gets the survey as the expert.
Yeah.
The key is CMS does not recognize this as a specialty. AMA does, but CMS does not. And it's CMS rules that apply.
I got a couple of texts, that's why I was going to bring it up. I was bringing the mic to Dr. Elias.
So it is key for our participation and most helpful to become defined. And that's right. The AMA has recognized phobology for, I don't know how many years now, some 20 years, but not CMS. Continuing on for the physicians, and just to underline the surveys and how this data is determined, and from a scientific perspective, the weakness of it. Physicians are asked a number of questions to record the amount of time they take during any particular procedure. Then they're given a list of reference codes. Okay, so compared to these other procedures, how would you say putting in a central venous line is, for example? And these are codes that have gone through a vetting process, if you will, their validity, they've been evaluated relatively recently, there's cross-specialty validation between them, so it's a reasonable way to go. However, the majority of the time, these reference codes are for procedures that the individual has never done and never does. It's part of a different specialty group. So, got to make sure I don't say anything out of line here. But for example, you may be asked, how would you compare a central line with doing a breast biopsy? Now, let me think something non-surgical. Okay, interpreting an EMG, for instance. Okay, the reference codes are routinely out of your specialty. And yet at the same time, this physician is asked to compare the intensity and complexity of the procedure at question to these reference codes that they've never seen, that they've never done. And at the end, okay, this proposed code, how many RVUs would you give it? Would you give it a 1? Would you give it a 5? Would you give it a 3? Okay, so these are examples of the reality of what goes into it. Okay, but at the same time, it's critically important, because what happens if your particular 35 physicians that answered this particular survey give responses that, well, you know, I can do, okay, we'll give phlebectomy as a perfect example. I can do a phlebectomy, the whole thing, in 25 minutes because I'm very good and I've been doing a lot of those. And you know, it's not very intense for me because I'm good at it, right? So what happens is phlebectomy being a very good example of that have cuts of more than 30% in terms of the RVUs, and by extension, the payments that were provided for physicians. And that goes along with the concept that you live and die by the survey. So we can stand up here and we can talk and do all sorts of examples on how difficult phlebectomies can be and what a challenge it can be. But if the survey results come out in a fashion that does not reflect reality, the specialty is stuck with those results. So you live and die. If the survey comes out that it takes 17 minutes to do it, that's what your reimbursement through the RVU process is going to be. And parenthetically, most of the time, those surveys and those results by the surveys are accepted at the 25th percentile. So it's not the average number of minutes it takes to do a procedure. It's not the median. It's usually at the 25th percentile. So it's critical for us as physicians and as a specialty, when these surveys are sent out, that we get as many people as possible to answer those surveys, number one. And number two, to think realistically, not how they think they do it and how good they are, but realistically, the time, the effort, and the intensity that it takes. Because once those surveys are brought back, then it's up to the advisors, the RUC advisors, to sit together, analyze the results, and try to construct an argument going up to the RUC itself to say, well, you know, this is what the survey said, but let me tell you, you know, 20% of the respondents lived in Texas, so you can't believe that, or whatever. The advisors have to put together a credible story to explain results that are really not in touch with reality, or at least to argue, listen, you got to take the 50th percentile, not the 25th percentile. It's not realistic. And this is where data comes into play. And this is where you can come across with saying, okay, this is the result of your survey of 37 people, but we did a national study and we had 1,000 cases of phlebectomies. And we have the data to show you that the actual time was twice that of the survey. This is where the data comes in and we can make the argument, because that's understandable and that would be acceptable to the RUC, because everybody on the RUC recognizes the potential downsides of these surveys, but you can't just go back and tell them, believe me, that's not true. This takes much longer. You have to have data. And so the registry is important, the app is important, publications are important for us. As I've mentioned to you, the implications for us, we have been active, we're there, we keep on top of things. I will tell you that without going into details and violating any AMA rules, we're very successful. The last meeting, We were able to collaborate with the other associated societies to modify the proposal that was up before the RUC on the venous treatments. We took the lead on that in accepting the support of the other societies, and we were the lead presenter before the RUC, and we did very well in terms of, as you all know, and I think I'm okay at least mentioning it, the reevaluation and surveys for the venous procedures will be done in 3 years. Whereas the initial proposal, shall we say, or the schedule on the table was to be reevaluated this year. So having 3 years is a great thing for us. As I've mentioned before, it's independent and it would be great to be a recognized specialty where we can be there as lead presenters, independent of just collaborations necessarily. So we need to become a recognized specialty. All right, let's take a brief look at the political aspects. So these are all the nitty-gritty details of physicians, the AMA, the RUC. As I've mentioned before, there's the second part, which is the political process. So most of the recommendations from RUC go up, they're accepted, but CMS decisions are final. And I don't know who in CMS decides what they're going to accept, what they're going to change, what they're not going to change. Those people are not publicly identified unless you know them, Robert. We don't know their credentials. We don't know their experience. But effectively, when CMS comes out in November and saying these are the final rules, that's it. Those are the final rules. You may have 30,000 public comments on their websites. When they make a decision, it's final. And the only way it can be changed is by congressional action. And they did that last year with the 3% cutting down the 3.75% cut to 3% in terms of the conversion factor. And as I've also mentioned, respectfully, the CMS is constrained. Congress made the rule 20 years ago that their budget for physician payment was going to be fixed, and they've got to be budget neutral. So their hands are tied without congressional action, and that's why advocacy is so important. As I've mentioned, their process, they make a proposed rule, as they did a couple of weeks ago in July. It's open to public comment. It's interesting, they are required by law to read every comment. So even though last year, I think they had some 30,000 comments, somebody within CMS has to read each and every one of those. Then they publish their final rule.
John,
Yes.
has there ever been a precedent where public comment has changed anything that we know of?
Well, we'd like to think so that to some degree, last year, individuals as well as we as a society commented on the proposed changes. In their final rule, they actually go back and comment on the comments and their replies. And although not by name, we were acknowledged in our commentary. So I do think it makes some difference. Yes.
Got a question in the back?
Yes.
So I'm from Baltimore, and so CMS is based in Baltimore, and I was, I don't remember the circumstances, it goes back 6-7 years, and I was part of observation of CMS making these changes and reimbursements. And the panelists who are making these decisions on particular, let's say, vascular or venous reimbursements are not necessarily vascular specialists at all. And so I remember this one panelist was an internal medicine doctor. Apparently, I don't know the person well, apparently very well influenced within CMS, who have an idea that venous operations are completely unnecessary. And so that goes into influencing the reimbursement code, CPT code, and then subsequent things that follow. And so the fact that we don't know who are the panelists who are making these recommendations based on certainly specialty surgeons making a recommendation, they have some opinions of their own and oftentimes some bias going into this that I'm not sure how would be best to approach those biases to have them understand that venous interventions really make a huge difference in patients' quality of life. But that's a question to you and the leadership here, how to make those changes.
Well, part of that is meeting, as we've done, meeting with CMS, meeting with the staff there educationally, and giving that information to them. They rarely can comment directly, but it's an educational process, both for them and in Congress.
So we do, we make comments to CMS when we go to meetings, and they do have meetings that are open. And I'm wondering, just does AVLS schedule those meetings and go to meetings as an organization? Or will they in the future? Because it's a good opportunity to meet with them. And obviously you have to have the data, like you said, to support your request. But we have seen changes made if the data supports the request.
So we met with them last year. We're in the process, and I'll leave it to others later, in the process of scheduling another meeting with them for this year as well. Yes, Martin.
And the 21st Century Cures Act also, if societies reach out to MACs and have unusually restrictive policies like Novitas had, they'll take a face-to-face meeting. There were 3 face-to-face meetings with Novitas. First Coast, through Dr. Chipman, asked our society, and we got the Cardiology Society, Dermatology, we had Michael Graves, you, myself, and Chris, talked to them about their policy. And if you look at those, they're very similar in medical necessity criteria, et cetera. So we've been active, but I don't think we try to make that public.
Hi, everyone. Andy Doris Molly, CEO of Koya. Great talk, great educational session. Can I speak freely?
I think we're all
Yes.
here.
No. I'll hold back if you like. So I'm actually new to the venous world, right? And I come from the eye care world. Very different. I've seen the whole explosion with eye care. Just dry eye disease that happens just with tearing of the eye, alone is like a multi-billion-dollar industry with great payment rates from CMS, both for procedural codes and at home. And I'm listening to you guys talk about to the elephant in this room, which is why doesn't anyone take a venous serious? It's such a devastating disease for patients, chronic disease. We've seen the etiology. Mark talked about it. So looking at it, it makes me wonder if we're getting lost in the tactical side of things, right? This code, survey, we live and die by surveys, is what you're saying. But the question I ask all of you is, we shouldn't be worried about living and dying, we should be worried about thriving. That's what we're here, right? We're here for great expectations. And the question is, where is reality today? Where do we need to be, right? And the question is, to me, it feels like we're getting lost in the tactical aspects of saying, this code, this particular procedure, what do we do, what do we do? And to your point earlier, with CMS change, it's too late by that. So what I would encourage from my own standpoint of being in eye care and having seen this show before, similar to Brooke, it's foundational to work on health economics and outcomes, the disease state. Why is the disease state burdensome? Ultimately, what is the cost to the population, to CMS? If we don't organize and have a standardized way of reporting that, it's very difficult for them to pay attention. And these things take time, but I would encourage us to think along those lines.
Andy,
I think that was excellent what you said, and having been involved with this committee as well, went along educating like John was just educating everybody here. I think one thing that came out of this, and Mark, you hinted at it at the beginning as well, is that this is a long-term commitment by our society. As John has said, interpersonal relationships in this arena really, really matter. So if 1 month I go to see somebody at CMS, another month John goes, another month someone else, who the hell are these guys? But if the society understands the commitment it takes
on an individual's part, John or whoever else, but also on society's part to develop the relationships we need to in CMS, in Congress. This is what John Mangold, was saying, where should we spend our money on? This is huge. This is one of the reasons why you want people to give money for the great expectations and everything else, because we want everyone to realize the amount of work it's going to take. We have to take the long view. It's not a quick fix, and that's exactly what you're saying, right? You can't get lost in the weeds in each particular thing. So I just wanted to highlight that everybody understands. This is going to be like a 5-year commitment to just get the right interpersonal relationships involved, so they understand venous disease, they understand how it affects patients, but they can't have one-offs going up there. And that's why we need the commitment. And John, you can take the lead, and Chris and everybody else, and Steve Darling. So it's great, but I want people to understand that.
So I will skip a little bit because I've already taken up my 30 minutes that Dean has given me.
Nobody needs to eat.
Oh, okay, all
I
right.
didn't think I'd ever hear you say it. I didn't think I'd ever hear you say that.
But all of this is, as was mentioned, will be available to you. I'll just highlight a couple of other additional slides. Last year, this was the bottom line, that CMS was proposing physician cuts of 13.75%. Through advocacy, of which we certainly participated. You've seen the money that we raised. We were quite active, not just us, but physicians as a whole. The total decrease to physicians was less than 4%. Okay, but the effects on venous specialists, which were prorated, so that effective now in July, you see here, based on the research that we paid for with Braid Forbes, okay, these are the calculations of the multiple venous procedures and the cuts. So overall, venous procedures last year had significant cuts, which we are living now. Okay. Now, for 2022, it's a deja vu all over again. 2 weeks ago, proposals for this year, the headline from CMS was rule to expand access to high quality care. That was their headlines when they put forth their proposals. What about it? A proposed decrease of 4.4% in that conversion factor alone. However, there's going to be additional associated costs, including year 2 of the clinical labor update, conversion factor to change for increased payments for evaluation and management codes, possibly the pay-go expenses from last year that were delayed. So we're talking about potentially a very significant cut for this upcoming year, 2023. So it's very real. MedCap, to put it in perspective, which is the advisory committee to Congress, mandated by Congress to give them a report on where things stand with Medicare, recommended continuing the total budget freeze on physician payments. This is something in the context of CMS finalizing 8.5% increased payments to payers for Medicare Advantage and Part D payments. And the hospitals were crying out that 3.2% increase for them isn't enough. While physicians are getting pay cuts in the future, there's a quick slide on physician payment at the bottom compared to payments for hospital procedures over the years. The effect on specialties at the bottom, primary care making payment reimbursement increases, particularly bad for venous disease, as we face a 9.1% inflation rate hike, the highest in 40 years. So what's the future of reimbursement? The future is right now. Progressive decreases in payments by government, the increasing supply costs, salary, and inflation threatens the viability of private practice. And we see this in the past. Back in 2017, when payments to vascular access centers were cut by 39%, 20% of those access centers closed. Medicare payment, i.e. treatment for patients, decreased by 30%. The number of independent private practice physicians has been slowly decreasing and significantly by almost 20% over the past 3 years alone. So that right now, 74% of physicians in the US are employed by either hospitals or venture capital firms. What does this mean for physicians? We just completed a member survey with OEIS, 165 physician respondents. I won't go through the demographics except to underline that essentially they're private practice physicians, 99% of them doing venous care, multiple specialties as reflected by us. 86% had a significant impact, negative impact by COVID. The changes implemented this year was felt to be negative or very negative by 94%. What does that mean for them for the future? 27% or about a quarter expected to close their practice in the next 2 years, or sell it, or become an employee like the other 74% of US physicians. Or finally, 43% anticipate retiring early with these budget cuts. So in short, COVID and the cuts in Medicare challenged financial stability. Large numbers expect to retire, sell, or close their practices, and any further Medicare cuts, and specifically the ones proposed now for next year, could cause irreparable harm, not just to physicians, but patient access to care. So in summary, these changes threaten the viability of private venous practices in the futures, with physicians going out of practice. Particularly in rural areas, it's going to be problematic for patients, and this is in spite of the fact that total healthcare costs will increase for us as a country. Finally, budget neutrality for physician reimbursement is no longer tenable if private practice is to survive in the US. This is not just a venous problem, it's a physician problem. All the major medical societies, including the AMA, see this as their principal advocacy focus for this upcoming session of Congress to eliminate budget neutrality. Congressional action is needed, but now more than ever, we need the support of the society and advocacy, not just for us physicians, but for our patients. Yes.